Welcome. Welcome to the next multiple choice question session on pharmacology. We're doing almost 200 questions on these sessions and it's going to be great. It's going to be useful to you. Question number 1 for the new session. Acute anginal attack can be terminated by verapamil, lignocaine, digoxin, nitroglycerin and propranolol. Acute anginal attack can be terminated by verapamil, lignocaine, digoxin, nitroglycerin and propranolol. I hope you know what's the management of acute attack of angina. That's very essential to know. What's the first drug in acute attack of angina to terminate the anginal attack? I hope you know it's nitrates and nitrates. That's nitroglycerin, and you can use nitroglycerin by sublingual route of administration, and that's the first drug to be chosen. Is a vasodilator, is going to dilate the venular circulation as well as the arterial circulation. The venous dilation is going to be more than the arterial circulation. It's going to decrease mainly the preload on the heart plus the afterload on the heart, and this is going to decrease the oxygen requirement and the pain is going to be relieved. So acute attack of angina, that's nitroglycerin. That's the answer. The next question, which of the following inhibits folate metabolism? You have to know the mechanism of action, and let's go to the options: erythromycin, doxycycline, pyrimethamine, gentamicin and ampicillin. So all the substances, all the drugs, all the options here are related to chemotherapy. They are all chemotherapeutic agents. Erythromycin, doxycycline, pyrimethamine, gentamicin and ampicillin. Let's start from E, ampicillin. What is ampicillin? Try to think it's from what class, and then we'll try to get the mechanism of action. That's the right way of doing it. Ampicillin is a penicillin, and common mechanism of action for all penicillins is going to be inhibiting the cell wall synthesis. So it's superficially, it's on the cell wall, it's not inside, it's not DNA synthesis, so not folate metabolism. D, next drug is gentamicin. Gentamicin acts on protein synthesis. We know it's an aminoglycoside, so protein synthesis. Next one, pyrimethamine. Do you remember anything related to pyrimethamine apart from malaria? It's useful in malaria. Do you remember any of the combination of pyrimethamine? Pyrimethamine can be combined with the drugs which can take part in the folate metabolism, which can affect the folate metabolism rather, and can act on the first step. I'm saying first step. What is the first step, second step? These are the established steps of folate metabolism. Para-aminobenzoic acid gets converted to folic acid to folinic acid. So I'm calling this as first step when you inhibit the enzyme PABA reductase. And this is done by sulfonamides. The second step, inhibition of the folate reductase or DHF reductase, is done by number of substances including methotrexate, including trimethoprim, including phenytoin, and your pyrimethamine is there, is acting on this second step. And the first step, I give you a hint, sulfa and sulfones and dapsones, they will act on the first step. So are you getting anything? Are you remembering anything? I am reminding you of sulfadoxin pyrimethamine combination for malaria. So this is how we analyzed, and we went up to the folate metabolism. Next option above that is doxycycline, that's B. That's a broad spectrum antimicrobial agent. So you know it inhibits the protein synthesis, and A, erythromycin, also inhibits protein synthesis. So we are left with pyrimethamine, which is affecting the folate metabolism. Folinic acid is not going to be formed, and inhibition of formation of synthesis of folic acid is going to lead to inhibition of the DNA synthesis. So the answer for question number 2 is pyrimethamine. We move to next question of this session. That's question number 3. All penicillins act by inhibiting the protein synthesis, inhibiting the cell wall synthesis, antimetabolite action, inhibiting nucleic acid synthesis, and binding to ribosomal subunit. Eventually, it was a coincidence. We discussed something on the last question, and that's coming to our help now. And let me elaborate a bit. The drugs which are called as beta-lactam antibiotics, there are two important major groups, is penicillins and cephalosporins. There are some other beta-lactam antibiotics also, and there are some drugs which are not beta-lactam antibiotics, outside beta-lactam antibiotics. Many of these drugs, including all beta-lactam antibiotics, they inhibit the cell wall synthesis. And because they inhibit the cell wall synthesis, most of the times these drugs are bactericidal. There is one more speciality about the beta-lactam antibiotics. They are supposed to have high therapeutic index, and you can give them in large doses, which does not happen with the rest of the antimicrobial agents like broad-spectrum antibiotics. So penicillins is cell wall, and don't just remember penicillin, also remember the other beta-lactam antibiotics including cephalosporins. Inhibiting protein synthesis, inhibiting nucleic acid synthesis, binding to ribosomal subunit, all the things are in a way related to each other, and many groups do it. It includes the macrolides, that's your erythromycin. It includes aminoglycoside, those are effective against the gram-negative aerobic organisms, streptomycin, kanamycin, gentamicin, etc. Inhibition of protein synthesis, the broad-spectrum antibiotics, tetracyclines, chloramphenicol. So many drugs are related to inhibiting the protein synthesis. And lastly, the antimetabolite action. In the last question we saw about pyrimethamine. But antimetabolite action, as far as the microbes are concerned, we have a very useful combination, that's sulfamethoxazole plus trimethoprim, that's cotrimoxazole. This is a classic example of antimetabolite action and drug synergism. So the purpose of these questions is not just to get the answer and go ahead, but to discuss about the other things which are related to this question. So we did it. So all penicillins act by inhibiting cell wall synthesis. So please remember this. Let's go to next question. Question number 4. All are induction agents except induction agents. What's the meaning of this? Unless we read the options, we won't know. Let's read the options. Thiopental, halothane, nitrous oxide, propofol, and intermediate. I hope you started understanding that we are in the chapter of general anesthesia. And as you know, when you begin the anesthesia, you want the anesthesia to begin very fast to have the effect, and this process is called induction of anesthesia. After this, there is maintenance of anesthesia. So the question is, all are induction agents except, means most of the following drugs are used for beginning of anesthesia. It means most of the following drugs are likely to be short acting. They produce the anesthesia very fast. The induction of anesthesia is very fast, and most probably their action gets over. So they are not used for long time. They are not used for maintaining the anesthesia. By long time, I mean a long surgical procedure, and they'll be mainly used as induction agents. Of course, if the procedure is short, you can consider these agents themselves to be used as a sole anesthetic, to be used alone for that short procedure, but the procedure has to be very brief, has to be very short. Otherwise, they are going to be useful only as induction agents. And you have the examples here is thiopental, halothane, nitrous oxide, propofol, and intermediate. I hope you know nitrous oxide, which is your laughing gas, produces a very rapid induction of anesthesia, but is not a very potent anesthetic, is not commonly used for long procedures, and it's an induction agent. It is used for induction of anesthesia. You also have on this list A, D, and E. That's A thiopental, D propofol, and E intermediate. All these three drugs are used by intravenous route of administration, and on your classification they will be written under intravenous anesthetics. And when I am coming to intravenous anesthesia, why I am going to intravenous anesthesia instead of inhalation? Obviously, these drugs must be producing a rapid effect, and our guess is right. They do produce very rapid effect. Anesthesia is very rapid, instantaneous, and the anesthesia will last for short duration. What's the reason for anesthesia lasting for short duration? Is these drugs enter the central nervous system to produce anesthetic effect, and very rapidly they come out of the central nervous system, which is called redistribution. So that's a common property of these three intravenous anesthetics, thiopental, propofol, and intermediate. So they are also induction agents. We are left with option B, and that's halothane. Have you heard halothane is used for short procedures only for induction of anesthesia? No. Halothane is a potent anesthetic, and it can be used for long procedures. So it's not only an induction agent. This drug is used for maintenance of anesthesia too. So all are induction agents except the answer is going to be halothane. Let me read the rest of the agents once again. Thiopental, nitrous oxide, propofol, and intermediate. They are induction agents. Let me take you to the next question. And the next question is question number 5. Most appropriate drug to control postpartum hemorrhage is. Postpartum hemorrhage, a very important condition. You will have to choose a drug which is going to act on the uterine smooth muscle and is going to produce compression of the arteries, and this compression is going to control the postpartum hemorrhage. So the drug has to contract. I hope you appreciate. So the drugs which do this, you have two drugs. Number one is oxytocin, second one is methyl-ergometrine. Oxytocin produces the effect mainly on the upper segment of the uterus. Methyl-ergometrine produces the effect throughout the uterus, and methyl-ergometrine is the one which is preferred for this purpose. So please fix it in your mind. Postpartum hemorrhage will be methyl-ergometrine and induction of labor will be oxytocin. Apart from this, there is prostaglandin analog, but the most appropriate drug to choose will be methyl-ergometrine. Oxytocin is obviously not chosen for this. It can be used if the patient doesn't respond to the other drugs. Progesterone is not useful for this. And last one, ritodrine, is a uterine relaxant. Obviously, we are not going to choose ritodrine. So it's an ergot derivative, methyl-ergometrine, and drug of choice for postpartum hemorrhage. Next question, number 6. All of the following drugs cause hemolysis in G6PD deficient patients, except. The options are pyrimethamine, nitrofurantoin, sulfonamide, erythromycin, and fluoroquinolones. As you know, there can be deficiency of glucose 6-phosphate dehydrogenase, and if G6PD is deficient, there is going to be less reduced glutathione, and this leads to the lysis of the RBCs. If this particular phenomenon of lysis of the RBCs is stimulated, is encouraged by the oxidant drugs, and there are many oxidant drugs which can produce hemolysis in G6PD deficiency. The bleeding can be serious in such patients, and you need to know if your patient is deficient in glucose 6-phosphate dehydrogenase. And there are some hallmark drugs which are contraindicated if the patient suffers from G6PD deficiency. And if you look at the list, I hope you remember your chapter of malaria. Pyrimethamine has got the most likelihood to precipitate bleeding in patients with glucose 6-phosphate dehydrogenase deficiency. So of course pyrimethamine is a drug which is going to produce hemolysis. Next one, nitrofurantoin and sulfonamide. Both these drugs, they also do have the susceptibility to produce hemolysis. The last option here, option E, is fluoroquinolones. What I would advise you is to remember them together. Nitrofurantoin is used for urinary tract infections. Sulfonamide is used for UTI. Fluoroquinolones are used for OTI. The meaning of this is all of them are useful against gram-negative organisms, gram-negative infections. Whenever you will think of gram-negative organisms in the urinary tract, you are going to think of aminoglycosides, no doubt. And after that, you will think about nitrofurantoin, sulfonamides, and fluoroquinolone. Remember them all together because all of them have got the susceptibility to precipitate bleeding in patients with G6PD deficiency. So the option which is left out here is option D, and that's erythromycin. We don't have reports about erythromycin producing bleeding in G6PD deficient patients. So the answer to this question is option D, that's erythromycin. All rest drugs precipitate hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. I take you to the next question. The next question is question number 7. Adverse effects of glucocorticoids may include all of the following except. Let's see if it's going to be a twisting question or it becomes easy. Adverse effects of glucocorticoids may include all of the following except. We can do something. We can just revise what are the adverse effects of glucocorticoids. That's going to be useful. And if you did not see the video for the glucocorticoid corticosteroid lecture, I would advise you to go and visualize that particular video. It will be extremely useful to you. It's something from high yield and it's going to help you to crack your entrance examinations, whatever examination you are aspiring for. So that's about glucocorticoids. Let's revise the adverse effect. I hope in carbohydrate metabolism, you know they are diabetogenic. In lipid metabolism, they produce redistribution of fat, moon phase, buffalo hump, etc. Protein metabolism, they are anti-anabolic. Calcium, they produce osteoporosis. These are certain important adverse effects. As far as the GIT is concerned, they are going to inhibit the prostaglandin synthesis, they are going to precipitate the peptic ulcers. And in the cardiovascular system, they lead to increase in the blood pressure, and they can precipitate diseases like glaucoma, epilepsy. They increase the intracranial pressure. So I tried to tell you most of the adverse effects, important adverse effects of glucocorticoids, and is going to help us to solve this question. Adverse effects of glucocorticoids may include all of the following. So it's good to know the adverse effects, you should always know, and this is going to help us to solve the question. A. Allergic reactions. B. Spontaneous fractures. C. Precipitating glaucoma. D. Elevated blood pressure readings. And E. Osteoporosis. Did I say most of the adverse effects? I think yes. Let's go to the options. Allergic reactions, I did not say. B. Spontaneous fractures, I did not say it directly. I just said it produces osteoporosis. And the reason of this is it increases the resorption of calcium from the bone. Calcium comes out from the bone to the blood, and this can lead to weakness of the bones. It can lead to fragile bones, and then spontaneous fractures are likely. So spontaneous fractures are likely. Next, precipitating glaucoma. Did I say this? Yes. Elevated blood pressure readings. Yes, we said in the cardiovascular system they are going to lead to sodium retention, edema, and they can increase the blood pressure. Last one is osteoporosis. We already discussed about its effect on calcium metabolism. So we are left with A. Allergic reactions, and even without knowing the adverse effects of corticosteroids, you could have chosen it because glucocorticoids are the most important drugs which are used to treat the allergic reactions, including acute anaphylactic shock. I hope you know this. So adverse effects of glucocorticoids may include all of the following except allergic reaction. This may not be the adverse effect of glucocorticoids. I think it was interesting. Let's go to the next question. Question number 8. Which of the following agents is useful in treating poisoning with an organophosphate poison such as parathion? This question is really important for you. Organophosphate compound poisoning is one of the most common poisonings in the world. Maybe with suicidal intention or maybe accidentally, but that's the most common poisoning, and we have options to save this particular patient. So you should take these options. Which of the following agent is useful in treating poisoning with organophosphate poison? Options A. Atropine and pralidoxine. B. Neostigmine. C. Pilocarpine. D. Carbachol. And E. Physostigmine. So look, many drugs from the same system have come together, and we have to choose an odd man out which is looking different than all these drugs. Before all this, let's know what's an organophosphorus compound. Organophosphorus compounds are anticholinesterase agents, and they are irreversible anticholinesterase agents. I hope you understand the meaning of the term anticholinesterase. Means they are going to oppose the enzyme cholinesterase, which is supposed to break down acetylcholine. So if you inhibit the enzyme cholinesterase, acetylcholine will not be broken down and acetylcholine will accumulate. So when there's organophosphate poisoning, the effects are going to be the effects of acetylcholine excess, the parasympathetic excess. And you already know it's acetylcholine excess. Look at your options now. Physostigmine, carbachol, pilocarpine, neostigmine. Are you sensing something? Physostigmine, neostigmine are reversible anticholinesterase agents. They are also going to accumulate acetylcholine, so you are not going to choose them. Carbachol is a cholinergic agonist, so it's going to stimulate the cholinergic receptor. Obviously we are not going to use it. Already there is accumulation of acetylcholine. The next drug on the list is pilocarpine. That's cholinomimetic alkaloid, means an alkaloid acting like acetylcholine. Obviously we are not going to choose it. See, if acetylcholine is accumulating, we need to block the cholinergic receptors, and to block the cholinergic receptors we need anticholinergic drugs. And I hope you remember one of the most important anticholinergic agent is atropine, which blocks the muscarinic receptor, and you have atropine in option number A. and it's writing and pralidoxime. Pralidoxime helps for regeneration or reactivation of the cholinesterase enzyme. So A is the right option, atropine and pralidoxime. Atropine to block the muscarinic receptor and to reverse symptomatically the effects of acetylcholine excess, and pralidoxime to regenerate the cholinesterase enzyme and decrease the manifestations of organophosphate poisoning. So atropine and pralidoxime drugs of choice for organophosphorus compound poisoning. That's question number 8. Let's move to question 9. Which of the following is most likely to be useful to improve cardiac function in a patient with acute heart failure? So it's about acute heart failure. You have to be cautious and you should use such a drug which is not going to increase the oxygen consumption of the heart too much. You also have to be cautious that this drug should not suppress the heart too much. And let's have a look at the options. A. Norepinephrine, B. Phenylephrine, C. Epinephrine, D. Dobutamine, and E is Propranolol. I hope you understand. Norepinephrine, phenylephrine, epinephrine, dobutamine, all four look alike because they are from the agonist of the sympathetic nervous system. And E. Propranolol is antagonist, it's a beta blocker. I think this examiner is wise, is trying to tempt you to choose Propranolol. When this happens, when you feel, oh, it must be Propranolol, wait a minute. Don't hurry up. Read the questions once again carefully and again go to the options. There may be something atypical, something very important, something very different which comes into play in a particular situation. And this is why the options are framed like this very wisely. We'll repeat. Which of the following is most likely to be useful to improve cardiac function in a patient with acute heart failure? And the options are norepinephrine, phenylephrine, epinephrine, dobutamine, and propranolol. Before hurrying up to choose propranolol, please remember what I said. We want a drug which is not going to worsen the heart by stimulating it excessively. We want a drug which is not going to produce excess myocardial suppression. We want to avoid both. So we want to avoid the interference with the heart and we want to have a better effect so that the myocardial oxygen consumption is going to be less. So if you look at all these drugs, are you finding something atypical, something very different? If you have not heard it probably, then that can be the right answer. Think this way. Norepinephrine, phenylephrine, epinephrine, all are the adrenergic agonists. We are not going to choose them. Propranolol is a beta blocker. It can produce sudden myocardial suppression. And you know beta blockers can precipitate heart failure. Beta blockers are used in heart failure and they are to be used in selected cases. And you have to be sure that it's compensated heart failure. And it's just said acute heart failure, you don't know anything. So the drug of choice in this situation is called dobutamine. Dobutamine decreases the myocardial oxygen consumption. It stimulates the heart, it increases the contractility, but it does not increase the heart rate. So the myocardial oxygen consumption is kept under control and it just leads to what is called selective ionotropic effect. So the choice for this particular situation is dobutamine. I showed you the answer. We go to the last question. Most specific treatment of digoxin toxicity involves. Sometimes we feel toxicity is important, digoxin is important, but simple words are important. The simple words on this question is most specific treatment. It's not asking you so many drugs. What is specific is being asked. So look at the options. Lidocaine is useful for digoxin-induced arrhythmias, correct? Potassium chloride, of course, is useful because there's hypokalemia. Propranolol is going to be dangerous in this situation because propranolol is going to suppress the heart. Next one is digoxin antibody. Yes, this can be useful. And next option, atropine. This also can be useful because atropine can increase the heart rate. Atropine can prevent the bradycardia, which is produced by digoxin. Now I took all the 5 names and I said this is useful, this is not useful. Tell me what appears to be specific out of this. We are saying digoxin toxicity and you have a very specific option here. Obviously, it's digoxin antibody. It's a specific antibody, fractionated antibody prepared against digoxin. So it's going to be most specific. Please remember, digibind is the digoxin antibody. It's a fractionated antibody, so it's called Fab. Capital F, small ab, Fab. So I show you the answer. That's digoxin antibody. Don't get tempted by lidocaine because it's useful for ventricular arrhythmia. It's correct. But let the examiner ask you a question. Which of the following can relieve ventricular arrhythmia due to digoxin toxicity? Then you go for lidocaine. But now the question here is, what's most specific? And most specific is digoxin antibody. I think you liked it. You must have enjoyed it. And all the best for your future examination and for your future ventures. Thanks for listening.